Okay, good morning, good afternoon, everyone. It's a pleasure to welcome to this session on COVID-19 health response and innovative just-in-time training in humanitarian setting, organized by different entities like CRIMEDIM, UKMed, European Master of Disaster Medicine, and No Fear. I'm Olivier Agon. I am the moderator of this course. Basically, I'm working at the University Hospital in Geneva. I'm anesthesiologist by background, the medical director of the Swiss Humanitarian Aid in the government of Switzerland, and I will try to facilitate this session. Today we have 5 presenters. We will start with Lina Echeverri, who is the health director of UKMed, EMDM alumni, and also member of the EMDM faculty. And she's also currently PhD candidate at CRIMEDIM. The title of her presentation is Induction and Just-in-Time Training COVID-19 Response. Lina, the floor is yours.
Thank you, Olivier. Can you all hear me properly?
Yes.
Okay, excellent. Thank you. So thank you, Olivier, for the introduction. So my name is Lina Echeverri. I'm a medical doctor and currently working as a health director for UKMed. And thank you all for the opportunity to present this training, to make it a stream to all the people who wants to participate and to learn. I must say that this is an amazing opportunity for all of us. So I would appreciate that at the end you have questions or comments so we can improve as well this training as we go along with that. Next, please. So who is UKMed? Very briefly, UKMed is a British NGO, is based in Manchester. UKMed was founded, and probably you already heard about Professor Tony Redmond. It was founded 32 years ago when it was born with a group of physicians that intended to respond to different humanitarian crises. The first one was the Armenian earthquake in 1988, so 32 years ago. This group of physicians grows so much to a register that englobe all national health system physicians in the UK. And after the outbreak in 2014, the Ebola outbreak, create the necessity to actually register UKMed as an NGO. As such, we have participated in many responses from sudden onset disasters to conflict, and lately we've been involved a lot in outbreak. We also make part of the UK EMT, and with the UK EMT, we have deployed to the Idai cyclone. We have participated as well in the measles outbreak last December, where we sent a team of physicians that participated and collaborated with the Australian EMT. And we as well participated in the diphtheria outbreak in Cox's Bazar in 2017, where we supported the activities of IOM.
Excuse me, I interrupt you, but no. I think the presentation, I can't see. I only see you.
You cannot see me. You cannot see the presentation. Shall I
I don't know, it's only me or all of.
Shall I stop my video, perhaps?
I can see the presentation really well.
We can see the presentation here.
Yes, sir.
You might have to move your screen to show a different view.
Okay, so it's okay.
So it's better if I stop my video?
Lina, you can go ahead. So I think it was perfect.
Okay. Thank you. So as I was saying, UKMed provides the medical workforce and the health coordination for the UK EMT, and this has been crucial in the late COVID response, where we have collaborated and supported strongly the WHO EMT Secretariat, the Ministries of Health, and the different WHO country offices and different UN agencies as IOM. Next, please. So what do we do and how we respond? So as I said, we participate in different humanitarian responses. Our idea is to respond to different types of emergencies, so sudden onset disasters, outbreaks, and we are also looking at responding in conflict. How do we respond to that? So we provide technical support that is looking at clinical care and so case management, for example, in the current outbreaks. We as well support in contextualizing all the clinical guidelines written by WHO and adapted to the local context. We build resilience through health system strengthening, training and capacity building of national staff and local facilities. And we believe a lot in knowledge sharing and therefore building resilience in these kind of settings. Next one, please. So as I said, our activities target clinical care, health system strengthening, enhance resilience through training, capacity building, and knowledge sharing. Next one, please. So UKMed and the UK EMT, it sounds a little bit awkward and many people confuse UKMed and the UK EMT. We are two different entities, as I'm going to explain in a minute. UKMed is an independent NGO, but as NGO makes part of the four partners composing the UK EMT. The UK EMT is owned by DFID. And as I said, we have been deployed in different responses, either in crisis, like in Mozambique, as I said, in the Cyclone Idai, in South Sudan, in Samoa, and now in COVID. But we as well support through training and capacity building in peace times. And we send our registered medical doctors, as you can see here in the picture, where we support training in South Sudan and collaborate with different organizations. We have a picture here of our team going to Samoa, but as well ongoing training and capacity building in South Sudan. Next one. So what is the WHO EMT and what is the difference between UKMed and UK EMT? So for the ones who don't know, the EMT initiative was born in 2010 after the Haiti earthquake. Perhaps many of you recall that humanitarian response was actually a shame. It was terrible. It was unorganized, and unfortunately, many clinicians and medical staff entered Haiti and did more harm of good. And I'm pretty sure that my friend Olivier can tell us more about that. So after this response, a group of physicians, and among those, Olivier Hagon, who is today sharing the presentation, came together with the aim to standardize humanitarian responses and allow as well the Ministry of Health of each country to own that response. So the first standards is the blue book that you can see on the right screen, and define the minimum standards that any team that will deploy internationally must have in order to provide humanitarian response. The blue book that you see here was published in 2015. It was asked for foreign medical teams, as you can read, because initially was thought of international deployments. That name changed, and today we call them EMT, emergency medical teams, because the idea is as well to create national capacity, and the national EMTs can deploy internally or regionally to support any type of response from, sudden disaster, conflicts, massive population displacement, of course, outbreak, as we are seeing currently in COVID. So what is the UK EMT? DFID from the UK government decide to verify EMT, please the following, and decide to verify an EMT. And so in 2016, this team was verified, and we have two types, type 1, type 2, and a spinal cord injury cell. So just for an information, EMTs can be classified as 3 groups. So type 1, which is basically primary healthcare and OPD activities that can be fixed or mobile. Type 2, which is a field hospital that includes inpatient care and surgical capacity. Type 3, that is equivalent to a tertiary level of care. And then you have a specialist care teams that can plug in and support different EMTs that can go from outbreak to IPC activities, or as we have in this moment verified, a spinal cord injury and with a rehabilitation component. In the UK, EMT is confirmed by a consortium or a partner with 4 entities, where UKMed is the medical team lead. And as I explained before, we provide all the medical workforce and lately the coordination of the deployments of the UK EMT. We as well collaborate with Humanitarian Inclusion, which provides all the rehabilitation support. The fire and rescue services of the UK which are in charge of the setting up of the field hospital when the field hospital is deployed, and Palladium, who does the procurement and the operational side of in country and in peace times. Next, please. What have been our contribution to the actual COVID response? So as you can see in the map, we have deployed internally a couple of experts in IPC to support the internal response in Manchester in a Nightingale Hospital. But we have as well deployed abroad, supported and embedded with WHO to Cambodia, where we sent a team of experts in case management, IPC, risk communication, and community engagement. We had a team with the same composition in Zambia. We sent an IPC support for South Africa response, Burkina Faso, who is my colleague, Angela Pekka, and as well a former EMDM alumni who will be presented to you. And the medical doctor that you see in the picture here is Frederick Mathieu, who has been since 4 months in Ghana, working side by side with the Ministry of Health and the WHO country office in setting up all the COVID response. We as well deployed 2 weeks ago a team to Cox's Bazar in Bangladesh, who are supporting IOM activities in Kutupalong and Teknaf isolation and community centers for COVID. Next, please. So what are the contributions as a UK EMT? We are grateful for the opportunity that WHO has given us to participate alongside with them. We have been supporting an adaptation of the WHO clinical guidelines to the local context. My colleague Veronica Sanchez, who will be presented to you in a minute, she has contributed and worked tireless with the EMT Secretariat in developing and designing the layout of the SARI Treatment Center and as well the community facility. These two guidelines have been published. So the SARI Treatment Center has been published already, and we're waiting for the community facilities to be published. We also designed, both of us, the screening and triage facility that has been used in different contexts. And with Luca Ragazzone, who as well will be presented to you, we designed the virtual reality, which is a tool for training and will be incorporated in the just-in-time training for WHO EMT Secretariat, and who that will be available as well in the app of the WHO Academy. Next one. With Veronica and with Nicolas Boudoukis, who is a log and an engineer in Greece, we had supported as well a local organization that works in Moria camp in adapting shelter in this camp that will be hosting suspected cases and relatives of confirmed cases in Moria camp, which is the camp that you can see here on the top. And this is another picture just to show you the response that we are leading with IOM in Kutupalong in Cox's Bazar. Next one, and I think my last one, I want to thank you, but I as well would like to do a little bit of provocation. And even though, and acknowledge that even though the COVID response has been of extreme concern for many of our colleagues that have responded frontline, we cannot forget that because of COVID, many of the crises have been forgotten, as is it the case in Yemen and in Syria, where continuation of care continues to be very difficult, and when health facilities have been targeted and prevented people actually with risk factors for COVID to have access to healthcare. Moreover, we cannot forget of the low-cost invasion in East Africa, which is threatening food security and livelihoods of our already vulnerable community. Thank you very much.
Thank you very much, Lina, for your nice presentation. Very interesting, and I think it was nice also that you took the opportunity to present the EMT initiative, which really is playing a key role for the time being. I suggest that we keep the question for at the end to make an open discussion with all the presenters, if you agree.
Of course.
Then now I will give the floor to Veronica Sanchez, who will present community facilities to care for COVID-19 patients. Veronica is a WASH Infection Prevention and Control Facility Advisor at UK Med, that was previously presented by Lina. And she's also working at the HCRI in Manchester. Then Veronica, the floor is yours.
Thank you very much. Hello all. As Lina and Olivier said, I'm going to present the community activities that we were designing the last week. Please, next. This is the publication that we are waiting for the final publish, and we developed with WHO and EMT. Next, please. Next. And then this document has 4 parts: the structure, the staff, the substance, and the systems. In this presentation, I am going to deep about the structure, which is the part that I am working on. There are different kinds of patients, as you know, and we consider this suspect confirmed a step down for the design of the structure and the layout. Yes, please. And the other thing that we consider is we have different sizes, and it's very important to adapt to the response. Then for the design, it's important to consider that we can have a small size, medium, large, or even extra large. 500 beds is the big number that we consider. Okay, next. Moreover, the place we consider that can be an existing place where we can adapt, or a new setup from zero. No? This different perspective. And also the construction can be temporary construction with tents of local material, permanent, or some kind of hybrid with both. Yes, please. Then the most important point to the design is that is modular and scalable. What that means. Next, please. We thought a layout that you can start with 60 beds if you want, and then you can extend in different phases with the patient inside without stop the function of the center. No, with the patient inside, you can extend easily, and you can have 500 beds at the end. Next, please. This is the layout for 180 beds, which we considered the more appropriate for a normal situation that can be useful. And as you see, we have a area for the staff and a technical area, and the triage, and then the wards for the patient. Any wards is a model of 40 beds, and the small wards with 20 beds close to the staff area is a singular for any other issues I will explain. In blue, you can see the toilet, and in red, you can see the place for storage and for equipment of nursing and the other parts. Okay, next, please. Okay, as you know, there are different risk areas, high risk area, low risk area, and the security distance. Are the 3 more important parts. Please. Yes. High risk is triage. You can see on the left, and the wards. Then pass, please. Next. Then the low risk. This is the staff area, and I want to maybe look at, you can show with the mouse the path, the corridor. That is a very important part of the design, because from this corridor you can see the patient without PPE. From the low risk area, you can see all the patient. In case that you need to go inside quickly, you have the quick entries. We will explain later. But yeah, and the security distance, the 2 meters. This layout can work properly also if you remove the distance and you put a wall with transparent windows. It's the same layout. Yes, please. Okay, then the areas that you have, the triage, the step area, wards, and supporting area. Next, please. Yeah, this is the triage, which is have a stabilization room, a place for waiting before and after the lab test, place for the lab test. And then from the triage, you can go to different areas. You can go to the confirm area, suspect area. We will explain later, but to have different options, very easily adaptable. Okay. Next, please. There's the technical area. In the right, you have the morgue, the waste management, and the laundry and sterilization area, and the step. Next, please. And then the words we saw before. Next, please. Okay, then the flows has to be very clear and no avoid crossing. Then you have the patient, staff, logistic materials, and waste is the circuit that we care about. That very careful with that. Next, please. And this is the triage and the flow that the patient follow with the protocols, and it's very important. I'm not going to explain that because it's the medical part, but as you know, is in close relation with the design and the isolation areas and confirm for suspect and from confirmed. It's very important to pass from the one area to the other without crossing. Okay, pass please. This is the triage in detail. It's a comment that we will share with you if you want, and you can see the blue flow for the staff on the right, and the green one for the patient never cross, and in many points you have the visual contact. Please pass. Yes, please. Here you can see the virtual reality that Luca and Lina were working on it, and it's a very interesting tool for the trainings, and it's a great work that they did after plans. And here you have the flow for the patient that you see the entry on the right and all the flow inside of the walls. Pass, please, next one. And here, yeah, you have the other circuit. The interesting part for the layout is that you can build with bricks, with plastic and tools, or with any different materials. The important is the circuit and the distribution of the space and the distance. But as you see, okay. And this is the flow for the staff. The light blue is without PPE and the dark blue is with PPE. You have the donning and doffing, and you have quick entries in case that you need to go quickly to any wards, no, directly. Go, pass, please. And this is the area for visitors in case that you consider that the visitors can go and see from outside, from the low risk, they can have visual contact with some parts of the center of the ward. Please. Next. Okay. Then the important other very, very important point is the adaptability for the suspect, confirmed, and other kind of patient that, as you know, with the epidemic is changing all the time, and it's important that the layout adapted. Okay, next, please. Next. And then, as you see, you can decide to have a part of suspect, another for confirm, or all confirm, and you can change with the easily movement of the layout and without stop the activity inside. Okay, pass, please. Next one. Okay. Yeah, here you can. Thank you. Here you have the on the right you have for suspect, for the confirmed, sorry, and on the left you have the suspect. The difference in the confirmed you have 40 beds, but in the suspect you have only 20 beds, and you have more toilet, one for any suspect patient, and they are isolated by curtains or walls or any kind of separation. They never mix. Next, please. Here you see the model, and the different adaptation that you can do with the toilet on the middle or around the place. Any distribution have some points that are better and some points that are more critical, but the important part is that you can adapt if you need it. Next, please. Okay, here, please you go passing all this kind of easy extension. We propose an easily construction for different contexts you can do, and you can extend as we explained before. Okay, of course, if you need any information detailed, I will be available for any question. Here, I'm sorry for this very technical plans, but it's just to demonstrate that were defined all the details for electricity, water, sanitation, and you can do the maintenance and the checking from outside, which for most people is very, very nice. Okay, without PP. Okay, and also in the document you can have any Excel and all kind of calculation about quantities and value and units that you think. About this isolation, there are also an annex where it's explaining all the points that you have to consider, the location, the communication, the security. Yes, please. And about the reusing the structure in the buildings, also you have that checklist and some consideration and criteria to choose a proper place to install the community facility. I think that is all for my part. I'm sorry I worked so quickly, but I am here for any question. Thank you.
Thank you very much, Veronica, for your presentation. Very accurate on the different perspective. And for sure, in such kind of situation, one of the big challenges is when a person is negative, when she or he enter into the health facility, that he will not be contaminated through the whole flow. And it is one of the big challenges that all the organization are taking care. Then the next presenter will be Luca Regazzoni. He's an assistant professor at disaster medicine, scientific coordinator at CRIMEDIM, and also EMDM deputy director. The title of his presentation will be COVID-19 virtual reality just-in-time training. And he did it in partnership or in collaboration with Ina, but it will be Luca who will present. Then Luca, the floor is yours.
Thank you very much, Olivier, for your presentation and for moderating us with your experience. It's my pleasure to present you the idea of modifying what Veronica has just presented in a virtual reality environment for training purpose. Our experience came from the Ebola response, where Lina and myself, we deliver and organize a training for all the humanitarian workers working at Save the Children during the Ebola response in 2015. So we started with a training in London, where we mixed virtual reality and face-to-face practical training to equip humanitarian workers in understanding how to properly donning and doffing PPE, but also to understand the working principle within the Ebola treatment center. As you remember, at that time, only MSF had an important experience in responding to Ebola. And MSF created a training center in Brussels, and most of the organization all over the world flew to Brussels to train there and to understand the working principle in the Ebola treatment centers, since MSF built a virtual, no, sorry, not a virtual, but a real Ebola treatment center, a small real Ebola treatment center in Brussels. So to avoid the traveling to Brussels, so we thought that creating a virtual reality environment was important to expose humanitarian workers ready to deploy to the environment to understand again how the Ebola Treatment Center works. And was really successful in London, but the most important part was also in the field. We brought the virtual reality environment also to the field to train local staff before entering the Ebola Treatment Center. So actually before getting the risk of the Ebola virus. So why virtual reality? Again, because simulate highly specialized real-world environment. Training can be done remotely, as we are doing now, ensuring access to a high number of staff is, of course, a safe training for high-risk scenario. And of course, we understood that there is an increment of the knowledge retention because the attendees, the trainee can see many times the virtual reality environment. And it reduces the cost, again, of traveling, but also of other costs of the training. And virtual reality simulation could also use in a hybrid methodology with a face-to-face and also a live exercises. And since the software that we are using is very flexible to change the different scenarios and the different environments, it's very adaptable to different contexts and to different needs. So before understanding how the virtual reality is important and why it's so effective, we need to understand the difference between the different areas, the different risk areas within a COVID treatment center. As Veronica said, we have area with high risk, we have area with low risk, we have triage area. In the triage area, as you can see from the table here, healthcare workers that are performing only preliminary screening, not involving the direct contact, needs only to maintain the physical distance of at least 1 meter. And if you are able to build glass or plastic screens, we can avoid the use of PPE. That is very important in this moment where we are, there is a global lack of availability of personal protective equipment. And otherwise, if you are not able to build glasses or plastic screen, again, if we are screening the patient, there is no, we need only to use mask and eye protection, as you can see in the right side. This is what Veronica just showed you, the different pathways and different flows of people entering COVID-19 facilities, the difference between the suspected cases and the confirmed cases. And this is the 2D layout of optimal triage area. But here, so the virtual reality environment can show you how to build it and how to use it. As you can see, this is the screen, the glass or plastic screen that avoid the need of PPE when suspected cases enter the COVID-19 facility and the triage or screen area. As you can see here. Otherwise, if you are not able to provide or to construct a plastic or glass screen, the healthcare workers can stay here without, only with the mask and a head protection, without the full PPE, because again, it's only a screening and we need to maintain the physical distance. And again, here you can see that the patient flow is far from the staff flow, and there is no need to stay in contact also with suspected cases. And then the patient, the suspected cases, can enter the facility and stay in the suspected area, far from the confirmed one. That is here, the confirmed area is here, far from the suspected, and with a protection between them. As you can see, the virtual reality environment is very useful to understand the working principle within a COVID-19 health facility. Entering the confirmed area, the ward where the patients are treated, this is the map that Veronica showed you. In this area, we need to wear the full PPE because the healthcare workers needs to provide direct care to COVID-19 patients. In this case, we are in the absence of aerosol generating procedure, we need to wear medical masks, gown, gloves, eye protection, and of course perform hand hygiene. But as Veronica said, if we are able to build the COVID-19 treatment center with the space, enough space far from the patient, we can have a low-risk area where also we can walk without the full PPE. In case we need to perform procedure with where aerosol generating procedure, for example, intubation, for example, non-invasive ventilation or invasive ventilation, we need to change the medical mask and use the N95 or FFP2 or FFP3 respirator. Because again, we need to avoid the possibility to get in contact with aerosol. In here, you can see from the virtual reality perspective how the facility can be built according to Veronica layout. As you can see, there are space from the different beds and also space in the middle where the healthcare workers can stay with not the full PPE because there is no full contact with the patient. I will show you how can we don and doff the PPE. From the right side, these are procedures that we are using here at the hospital in Novara, and this is exactly at the infectious disease department. In this case, we are using 2 pairs of gloves. It's not mandatory. It's our choice to use 2 pairs of gloves. This is a FFP2 respirator. Also, the hat is not mandatory, but is recommended. Also, when you cover the shoes, is not mandatory. In our case, is recommended. This is mandatory. So the shield. Okay, I will show you very briefly the doffing. In our case, we are washing hands in every steps. Okay, since we are we need to stay in time, I will send to you, to all the attendees, the video. You can see the actual doffing in our case. To conclude, I will show you also how the virtual reality environment can be used in refugee to expose humanitarian workers to another scenario like the refugee camp. And this is the layout of a refugee camp with the triage area in a tent and the treatment area. So this is the screening, triage, and the treatment area. So final words, again, so we need to stay, to pay attention in using the personal protective equipment. And these are the most important part in to optimize the PPE availability, to minimize the PPE need, use the PPE appropriately, as I said, and of course, coordinate the supply chain. Thank you very much.
Thank you very much, Luca, for your very interesting presentation. And obviously, to move into a simulation will reduce the cost and increase the efficiency, but also will have a very positive impact on the carbon footprint for people who just try to take care of our planet. Then our next presenter will be Emanuele Bruni. Emanuele Bruni is currently working at the planning and monitoring and evaluation acute event monitoring in the WHO emergency program COVID-19. He has a former experience as a medical anthropologist, lecturer and field researcher with a focus on Ethiopia medical system research, and he did it from 2007 until 2013. The title of his presentation will be Risk Communication and Community Engagement COVID-19. Then Emanuele, the floor is yours.
Thank you, Olivier, and thanks to Angela for allowing me to be before, because I have a call at 4. So thank you really for your flexibility, and to the others, of course. So risk communication and community engagement. Please, next slide. Let's accelerate. As Olivier was saying, I normally work on planning and M&E, but I have a former experience as anthropology. And I'm pleased to present about this important pillar of the response. Why? Because normally in the humanitarian and in the response, this side of the, when I talk about public health mostly, is a bit, let's say, neglected. And this is because, of course, there are priorities that are a bit more urgent, and it's totally understandable, especially in terms of infection prevention control and case management. However, especially for COVID-19, risk communication and community engagement is very much more important because we don't still have a cure, we don't still have a vaccine. So the only cure that we have is actually the communication with the people and making sure that the epidemiology approach might be well absorbed by the population. So we consider this exactly as a training, epidemiological and laboratory analysis. Next slide, please. So how do we do that? I've been working in Ebola for, let's say, a couple of years and during the former outbreak, and we know that building trust is the key factor to enter in the heart of the community. We need to enter into the intimacy, and this might allow us to have a better compliance. If we don't have a compliance, the community doesn't participate to the cure, and the disease continues. In other cases, the community might also attack the response, and I can tell you it's not an easy experience. How do we do that? We want to know what is the perception of the risk, the interpretation of the disease. We want to communicate to the community, and we want to prevent stigma, and we want mostly to understand what could be a good behavior for us. So let's say how to feel this virtual reality that was extremely impressive. I have to say I'm very impressed, but would be good also to think about how is our behavior as let's say humanitarian or health workers. Next slide, please. So this is a slide I borrowed from the Red Cross. The Red Cross is kind of modeling this new approach for COVID. As population is very important, especially in terms of public health and social measures, which is the term that we use now in WHO for the so-called non-pharmaceutical interventions, we think that people are the real center of that. And to do that, we need to go through the rumors tracking, which is also a sort of community alert. We need to produce a social evidence to that, engage the community, be extremely coordinated, and build a lot of capacity. This is what we are doing now, and we have to do that always with the community in mind. Next slide, please. This is just a joke, of course, but I wanted to introduce the whole story of the elephant, because at the end of the day, this is the perception of the risk, and each of us has absolutely a different perception of the risk of COVID-19. And we have to imagine this also in different communities where, like very smartly Lina was raising, maybe COVID is not the main problem, but still is a huge problem. And so let's not forget that, of course, the perception of the risk has different interpretation. The more serious slides about that, if you can go to the next slide, please, is the model we used to have in medical anthropology. The model on the left, the sickness, illness, disease, is kind of a must in anthropology. The three names that we give: the disease as the biological, let's say, way to see the disease. The illness is the personal from the patient point of view, and the sickness as the social and political ring, whereas this happens. So this is, of course, happening through biological factors, environmental factors, and mostly, let's not forget about the sociocultural factors, which we are going to approach. So we are talking about these structures that are going to contain the emergency medical teams. Okay, so what is happening within these structures is important, and what is happening around these structures is as well important. Next slide, please. Another important element of risk communication is absolutely information. There is high demand during an emergency. There is a urgent time frame. The population wants to know, the politicals wants to know, the actors want to know, and you need to disseminate it properly. So there are several channels and different audiences. Let's not forget also that there are some terrible audiences, but they are very important for us. They are the so-called donors. We have to inform them to understand what is priority and what is instead not priority. And we have to share this. On top of this, and especially for COVID, but we were experiencing that also with Ebola, rumors and misinformations, they might play a role. In COVID, unfortunately, also there are some high-level political people that are really spreading strange misinformation. I just heard yesterday about a case of a pastor that was prescribing Dettol to be drunk in some rural area, and it caused a lot of I mean, I think some people died, absolutely. So let's say misinformation can bring really to dangerous outcomes. Next slide. How do we call that? In these days in WHO, they have invented a term that's not really the most beautiful to hear, but is infodemic, intended as an epidemic of bad information. It's not really a nice term etymologically speaking, but it gives the sense. It announces a lot of stigmatizations, discrimination, misconception, and so on. So the role also of risk communicators and the role of the health worker is making sure that this infodemic is not affecting us or is not affecting people. Because if people don't know what they have, are not afraid, are not aware of the response that you are providing to them, they're not going to use the structure, or they're not maybe going to adhere to the program. And so you might have the best people there, the best structures, but still you don't have the participation of the community. Can I have the next slide, please? And community engagement is always not a matter only of sharing a message, but is always, the basic of community engagement is always a two-way dialogue. What do I mean by that? Feedback from community is absolutely important. It doesn't mean that, of course, they help me to define whether I have to wear a mask or not. This is on the scientist, but it's helping to define how am I perceived when I explain the mask use or not, or how am I perceived when I explain the hand washing, the triage, or for instance, also the field hospital per se, which could be perceived as a basically death sentence place, because everybody that goes there maybe doesn't come back sometimes. And so we need to dialogue with the society. And this is basically the essential basic level of community engagement. Next slide, please. We need to establish this communication with different target groups. Each target group has a different type of message. Healthcare workers, I think the message that was driven, for instance, by the video, Luca, but also other messages more related to the mental health of healthcare workers are extremely important. Team leaders, they have a different type of messages. People in isolation, how do we communicate with them? And so on. So all this we need to explain, to have a kind of target group. I will provide some materials for the induction that we will do next week, of course, because it will be interesting to have really some example. Now, for shortage of time, we can't go through. Next slide, please. This is a very old slide we used to do when we were in Ethiopia. And this is the health-seeking behavior. In French, it's called itinéraire thérapeutique. So it's like therapeutic way to get to the cure. And this is not so straight as we think. It's not like I'm sick, I go to the health facilities. Not at least in countries where there is a huge presence of traditional medicine, where there is social stigma, where there is health inequalities, and where perception of a medical team might sometimes be also related to some kind of government and political issues. Like, for instance, in DRC, Congo, many people were not adhering to the cure because the Ministry of Health was bringing this cure. And the Ministry of Health was, let's say, from a very far place from where we were. So this is also an important issue to take in consideration. Next slide, please. I was isolating here a bit of, let's say, important way of communicating with patients. I'm not going, of course, to list all of them, but of course, it's very important to be respectful, to be very clear about what we know, but also it's very important to say a lot of things are still unknown about COVID-19. It's okay to admit, I don't know. It's better to admit, I don't know, and to show that we are still sharing this unknown rather than saying things that are imprecise. Then I added, I'm not sure that all the medical doctors here will adhere with that, but we are promoting sometimes also when there is a PPE protection from the health workers, maybe sometimes we can even touch patients, because maybe the contact in some kind of cultural context might be important. I'm not talking about strong touch, but maybe also shaking the hand or touching the shoulder would make the difference. So I don't know if this is, maybe I'm not correct in that, and in case, please don't consider it, but from an anthropological point of view, this would really make the difference. Next slide, please. Well, this we can also skip, but basically it's about the importance of the family, of the people that are isolated. And of course, It's important that this brings hope. It's important to recognize that once the person is discharged and is into a health facilities, the family of the person becomes the staff that is taking care of this. And so we need to create this connection with the family and with the patient. And it's very important. I know how difficult it is for health workers to keep people informed as much as we can about the progress of the cure. Imagine also that the people don't speak your language, so there is a huge communication gap, also levels of expertise and maybe of knowledge about what is biomedicine, what is health, and what is body. And so the more we are communicating in a clear way, the better it is. Next slide, please, thanks. Important factor is what brings to social stigma. This is an article that I downloaded from the Red Cross. The issue is WHO, UNICEF, and Red Cross have a tripartite agreement, and we work as one in that. And the colleagues from Red Cross, they isolated the main factor that bring to social stigma. Ideally, when there is a new disease, there are many unknown. When there is many unknown, people are afraid. Human beings are afraid of things that are unknown. Once there is something unknown, they associate the fear to the unknown, to the other. There is a word which is called, it comes from Greek, is xenophobia, which means the fear of what is stranger to us. It's not only to be racist, it's the fear of the stranger, the fear of the unknown. This can bring to harmful stereotypes. So we need to go across that. For this reason, next slide, we isolated a bit of what could be the do and the don'ts. Could you please go to the next slide? Excellent. So I'm not going to read all of them. I would like you just to keep that. But basically, essentially is let's try to maintain a kind of positive approach as much as we can. And so let's not say this is, of course, the initial example is the one of the Chinese virus that was, of course, something that was across the web for a while, but also maybe better to say acquiring COVID rather than transmitting COVID. Maybe better to say, to use very scientific evidence rather than use some kind of journalistic type of language. And finally, always trying to show that the measures that we are promoting, they have a positive outcome. So the do and don'ts are here. You can read it maybe later, and I hope this could be helpful just as a kind of checklist. And final slide, very important, is not only what we say to the community. It's not only important to have a dialogue with the community, but it's also important to see how the community look at us. So I've been in the field for so many years, like Luca, like Lina, like Olivier, and like many of you, I'm sure. It's normal to feel stressed. It's normal to feel sad. So it's not about not sharing that. It's about accepting that. It's about getting ready for that. And what we promote is also, let's be aware of work shift. I'm normally, people, they start in a kind of honeymoon approach and they work 16 hours for the first 2 weeks, 3 weeks, and then they collapse and they go in burnout. Let's be smart ourselves. It doesn't matter who we are. If we are IPC or nurses or doctor or anthropologists, we work as much as we don't get exhausted. Let's try to have health habits. And this is not only about smoking is bad and drinking is worse, but it's more like also about how the community perceives us. If the community start to see that after we go out of the EMT, they start to see us going partying around because we need to decompress. This could be good, but in the same time, it's also very bad to show because maybe there is a situation of bereavement and of, let's say, perception of sadness. Let's maintain a buddy-buddy system. For those who don't know, it's basically having a colleague, a friend that with whom we are always in contact that could be our, let's say, angel. And let's find a way in teams to have ways to communicate and discuss the distress, because it's very important sometimes just to get rid and vent aloud. Then, of course, relaxation techniques and other systems from your organization should be provided, and I'm sure that any important international organization has this. So for the moment, this is all. I will be happy to share more later, and I will leave this call soon. I'm sorry. Thanks.
Thank you very much, Emanuele, for your very interesting presentation. And I think for me, I do see also a very big challenge is how to communicate when you don't know. Because as you know, this virus is a virus that we need to study a lot. And also regarding fake news and stupid rumor, like when you have someone who is in a very high position, just to recommend to make an infusion of disinfectant, sometimes we need to have a bit some external thought to say that this is not something that needs to be done. Now, I'm sorry we are a little bit behind the schedule, but I think it's very important to listen all the presenters and to let time for question. Now it's Angela Pekka who will give a presentation about the response on COVID-19 in Burkina Faso. Angela is a nurse in UKMed and also a member of the EMDM alumni. She has a national experience on the National Health Service in UK for 7 years, progressed to have an international experience, namely with UKMed in Malawi and also with United Nations in Mali. And she is currently on deployment in Burkina Faso, responding to COVID-19 pandemic through the UK EMT deployment. Then Angela, the floor is yours.
Thank you very much, Oliver. Hi, everyone, and I hope, first of all, everyone can hear me. So thanks for the presentation, and I think actually my presentation, it's perfect just after Emmanuel's, because there's a lot of things to apply to the ground that he mentioned. So a lot of context things. I hope I can, over the next 10 minutes, do that and give you an overview about how it is like working on the ground for coronavirus response. Namely, I'm in Burkina Faso at the moment. I have been here for around 5 weeks now, coming up. And as you can see in the first slide, my experience is in a dedicated coronavirus hospital, which is the one that you can see over there. It's actually not very old, which does help in terms of infrastructures, but it's not only infrastructures that are important. So progress for the next slide from that. So I also wanted to add a little bit of a touch about Burkina Faso. So as Emmanuel mentioned, is not only just about going on deployment, but actually know the ground, know the people, know the culture, and see what kind of strategies are the best in order to apply the response. Okay, so this is one of the first things we have to do on arrival. And one of the mottos that we have here, citations that we use a lot by Burkinabe, is this one, which translates into discouragement. It's not Burkinabe. So they're actually a very resilient population. They always are very happy to help and very available, always with a smile and always saying yes to everything, or we, because they speak French. So it's actually very important. So they're always there. They are very resilient. But at the same time, they might not express necessarily, their own concerns and fears and difficulties. So actually, that was one of the things that I've identified, and therefore we also tackle that through one of the trainings. So we can move on to the next slide. Perfect. So I've already been, presented, so you don't have to do much more intervention than that. But basically, at the moment, I'm part of the UK EMT response in Burkina Faso. I'm also an EMDM alumni, so welcome to everyone for EMDM as well. And what am I doing here on the ground is actually reinforce, being part of the surge capacity. So reinforce the local resilience. In order to put systems in place that we're going to be using towards perhaps a surge in coronavirus cases. So surge capacity, as you might know, is composed of 4 different things. And that's why they are stated, so structure, system, staff, and stuff. So what we want to do is put things in place that we can use if the demands are actually bigger than the capacity that we have here to receive them on the ground. And we can move on. Okay, so in terms of the context, so I'm in Burkina Faso. So Burkina Faso is a landlocked country by several countries, as you can see in West Africa. So that plays a role also where you are. So it's part of the Sahel region, which comprises 5 different countries. And has a high security and also terrorism threat. Also, as you might think, it's quite warm here. So it's also other difficulties that you have to, that you have to think about when you're responding to a pandemic, where the use of PPE is extremely important, and therefore is one of the difficulties perhaps encountered by the staff. I'm actually based in Ouagadougou, which is the capital city of Burkina Faso, and in the namely specific hospital. And I'm working also very closely with the local NGO, which is embedded in the hospital. So the deployment is roughly around 6 weeks. So I've been here, only one more week to go. So going back next week, but I'll give you an overview of what I've been up to in the last weeks. Next slide. Perfect. So this is, what I'm here for, to do some capacity building, and you can progress to the next slide. So on arrival, we basically made a decision that I will be the, IPC manager, so the infection prevention and control manager here on the ground. So this is the experience that we've been having. We also obviously are available for other things such as case management. But this is the main thing that I've been doing, and I'll explain to you what are the objectives in terms of infection control. Next slide. Thank you. Okay, so upon arrival, again, was very important to work with the team that has been on the ground here. So with the staff that have been working continuously since the beginning of the outbreak. And therefore this was identified with, a whole range of people. And I will also tell you who are these people that are involved. But specifically about structure, there was a huge need of improving the triage layout. So the triage was not really enough for, the current response and the current numbers that we had here on the ground. So there was a highly need of doing so, and as well signalization. So the patient's flow through the triage, it wasn't clear. It was also very, confusing for the staff to know where to go, and also even for the patients and visitors to come. So that was also something that we had to improve. And then the system was the next one. So staff have been here also, but perhaps not with a, with a very strong training. And this training in all levels. So not only in procedures, such as, hand washing and mask wearing, but as well as donning and doffing and PPE wearing. As Luca also touched upon that, but as well in mental health, as Emmanuel mentioned. So there is a consideration, a very actually high consideration in the current pandemic response, which is named by the WHO, which is actually attend to the needs of the mental health of the personnel. So this is one of the things that we have been doing, given the fact that it was identified here on the ground. The last one was really strengthening the IPC cluster. So this was something which was not really in place. So different organizations were working individually and not really together. And therefore, I think a closed approach and an embedded approach with all the stakeholders is quite important in order to streamline the IPC measures and also learn from each other, because again, everything is very new. We don't know all the answers, and perhaps something that has been validated and has been used in other contexts perhaps might be helpful for our own. So next slide. Next slide, thank you. That's perfect. So in regards to the first one, improved triage layout, signalization, and flow. So in regards to the layout, we have proposed a layout which was actually constructed by Lina and Vera as well, which are they both here. So this is one of the things that we can actually, construct independently from the hospital. So, for example, the hospital that we are at, and actually I'm currently at, doesn't have a dedicated, built-in triage zone. So we actually built, our own. So this is a project to reinforce and increase the capacity. As you can see, the triage, when we arrived, and you can see that on the picture when we arrived, the triage was not very, clear signalized, and also didn't have capacity for many patients, so 2 patients at the time only, and it was not very stable as well. So weather-wise, we've approaching the monsoon phase here in Burkina Faso, so we had a lot of difficulties also to get a more stable triage area. So that is on the pipeline. The signalization when we have the new triage is going to be also set up. And we have worked closely with the staff on the flow. So it's not only about putting, things in place, but also speaking to the staff and actually, reinforce what is the actual circuit that they have to take, and as well to the patients. Next slide. Okay, in regards to the second point is reinforcing staff training, and we've been doing I've been doing several staff training, namely about standard precautions, as I mentioned, hand washing, and also mask wearing, and quite important about actually the fit test. So are we actually doing a proper fit test when we enter a red area or not? And some of the things that perhaps it might not be already here. But also there is some awareness on the ground, and I think what the main challenge has been is getting the message across that this is not Ebola, and there are a lot of myths, which I also tackled in one of the training programs which we had, which was about staff well-being. So we didn't not only do about PPE and donning and doffing and also standard precautions, but as well in staff well-being, which is the kind of the picture on the corner, as you can see, the top right-hand corner. So staff well-being and stress management, which they actually opened up about what Emmanuel just mentioned. So all the rumors they are around. So actually there's a lot of people in society here which think coronavirus does not exist. It's just, it was made up by someone perhaps, in leadership positions, and there's also stigmatization towards healthcare workers. So they actually feel very isolated, and I think motivation is one of the trainings that and the support that we've been providing here on the ground, and also is about delivering the training to the staff. So when we have this, PPE training, actually go myself to every single ward, work with every single team on the ground, and not necessarily them coming to me. So I think that's quite important to also show our availability and work alongside Burkinabe staff, which has been here on the ground. So not only training staff, but I've been also training the trainer, which I think perhaps is a good message to send out. So it's not only about the weeks that I'm here, but actually build a strong foundation for when I leave, what is left, and can someone carry on, because we are still perhaps recruiting staff and we're still putting things in place. Next slide, please. Great, so this is the strengthening of the IPC cluster. So as you can see, there's different stakeholders here. So the first one is Alima, which is a local NGO, which has been on the ground for a while. And second one is actually the hospital that we're working with, partnering directly with the third one, which is the Ministry of Health. And then we have local WHO. So all of these different stakeholders are important, and they normally have focal points for IPC, but there is not a clear meeting with everyone, which actually let's just talk about things. Let's see what is the main challenge, what the applicable things that we have. So at the moment we're having a weekly meeting on every Monday with all different intervenients, and also tackle the most emergent problems that we're facing, and perhaps do some recommendations too, in order for Ministry of Health to issue guidelines. So there's another challenge that we've been facing is not only about following WHO guidelines, but also adapting the guidelines to the context and to the country and to the fears and myths and knowledge that we have on the ground. And therefore, that's been a quite good relationship. Next one. And I just put this out here. So after action review. So it's not only about coming here, but actually thinking about, what we are here to do, what was supposed to be happening, and what actually happening, and also lessons learned, because we're always, again, learning from every step on the way. And that's why it's so important to just-in-time training, so we can learn from each other and from other regions. So UK EMT is being deployed, as you saw from Lina's presentation, all throughout the world. So we do these trainings in order to improve ourselves and improve our response as and when we speak. So I guess more than in a week time, I will have a little bit more to share about what can be done differently or improved. Next one. And thank you for everything. And I think that's me, Oliver.
Thank you very much, Angela, for your very interesting presentation, and I think it gives also the flavor of the field, and I think it's very important to see what do you mean by practice. I think we completed the 5 presenters. I would suggest that maybe Luca, if you can collect the question, and maybe we collect a few questions, maybe by message, or what do you think would be the easiest, is message?
Yeah, I think by chat is the best
By
way.
chat, sorry.
Yeah.
I'm old, that's why I'm using message and not chat, but I'm sorry.
Yeah, no, sorry. I think we have already some question. I'd be interested in the actual IT program that you are using for the virtual reality training, Luca. Is it available to other organizations? Okay, so it's a question for me. So basically, we are using XBR. Is a software available in the market, and we, as a CRIMEDIM, we have a license to use the software. And we have no stock on, so we bought the license, and we are still using the software. But again, so as I said in other occasion, so the company is very flexible, and also is willing to support humanitarian organization. So during the Ebola response, the company released many licenses for free to use the virtual reality. And of course, what I've just shown in the presentation, the video and all the scenario we created, is of course for free. But if you want to have the software itself to create your own scenario, we need to go to the company and ask.
Okay, do you have other question, or?
There is another question. Seems for the both layout plan and virtual reality, it is for new structure. Is there any guidance on existing structure? Maybe Veronica.
Yes, thank you for the question. Yeah, this is for the existing, this layout, you can implement it in a place that you have a big roof. But now we are working to design a roof for that. And in the document, you can also find some criterion recommendation on how to build things in a existing building.
Another question is also for you. Also, for aerosol generating medical procedure, there is a separate dedicated area.
Excuse me?
So basically, they are asking if the layout you have design has a specific area for procedure that generate aerosol, like non-invasive ventilation, mechanical ventilation.
Yeah, in the section of system, there are some specification for different kind of aerosol generator, for different kind of ventilation, and yeah, the document gives some option that you can choose.
Okay, thank you for the informative presentation. There is a way to get the slides. So the record, of course, it will be available. The record, also the slide from my side will be available. I don't know. I will ask the other present. We will ask the other presenter. But
yes, so if you want, you can collect all these slides, Luca, and then we just can publish them or share with the participants via mail. No problem at all.
Then for Angela, are you deployed alone to Burkina Faso? Are there not like National Emergency Operations Center in place for the national coordination of the response?
Hi. Hi, Luca. Thank you for the question. I believe it was Dr. Moore that you know, made the question. So from the UK EMT side of things, I am deployed on my own, but obviously it's a specific response, and we are working with a local NGO which has been on the ground for a while. There is Operation Center, but as the role I'm doing here is very particular and very specific to IPC, that's where we're trying to strengthen, rather than which we didn't have necessarily for IPC.
Then we have another question for Veronica. The layout, about the layout. How do we manage VAST in the isolation center? The VAST management.
I'm sorry, I didn't understand the question. How we? I didn't listen to you, and I am looking on the
waste management.
Waste management. Thank you. Yeah, waste management. We propose two areas: one inside from the high-risk area, and the other outside for infected and not infected waste. And in the high-risk area, you have the separate waste, the medical, then the shapes, then the different kind of waste. Yeah, it's on the right, and it's very similar to medical waste management, and also similar to Ebola waste management.
Okay.
In any case, yeah. In any case, when the document is published, you have a very detailed specification about all these protocols and characteristics.
Another question for Angela. Great job, Angela, in Burkinabe. How will you rate the program impact? How many cases were they reporting in the facility on arrival and currently after training?
In terms of reporting cases?
So basically, he's asking how you measure the impact of your program. So if there is any positive impact in terms of decreasing of number of cases.
So I guess my main focus here is again for infection prevention control, but that's a very, very good question. So how do you actually measure that? I think worldwide, the view that we have at the moment is actually 0% of infection staff. So that is actually the goal that we want to. And also perhaps what you're saying is reportedness from the staff also, if they're actually, reporting and not reporting when they are not sick. So I guess, first of all, one of the things that we are seeing is the staff is much more aware about the things that they have to report. So the proper channels, and that was also addressed in staff well-being. So what would they, actually do? And we haven't had any so far cases of staff that have been infected. And again, it's about collecting also feedback from the people. But I think two measurements that we can check is actually people reporting if they are sick. But at the moment, there's no sickness that we have in the staff here in the hospital.
And another question, are staff being proactively tested?
actually a very good question as well. We're not really proactively testing, but we are doing checks, so on the door, but just temperature checks. We are testing people if they do have symptoms. So that will be the only case.
Okay, it seems that there is no other question.
Okay. Do we want to, I just want to say a few words for the conclusion, and we proceed for this, or?
Sure, thank you,
Okay.
Olivier.
Then, I think for currently, as you all know, we are facing a real pandemic, and I was just checking before starting this webinar on the Johns Hopkins dashboard that we have now 5,600,000 cases confirmed, and more than 350 fatalities, which is absolutely a terrible number of deaths. In fact, this pandemic affected also not only low-income countries, but also high-income countries. And Italy, Spain, UK, and other countries in Europe were facing terrible challenges, and I think they paid a very huge price. And for us in Switzerland, we benefit for the previous experience of our Italian friends, especially from Luca, and also all the friends in Lombardia, and also from all friends all around the world. And it helped us a lot to increase and to improve our preparedness. And to have such kind of webinar to exchange experience is very helpful, because it can help each other. It's not only people from very academic institution, but it's also people who are working in the field, who are sharing experience, and I think it's very, very important. The other thing is we need to avoid the tunnel effect. You know, COVID is a terrible pandemic, but it's not only COVID. You know, a health system, which is terribly affected now, needs to provide a lot of different care, like care for mother and children, like deliveries and OBGYN activities. NCD, you know, it's also other communicable disease like cholera or measles. And also the issue of mental health. And mental health is not only for patients, but it's also for healthcare workers, because it's also very challenging and very difficult. And I think we all know what does it mean to be involved in such kind of pandemic. And to build on what was said by Lina to the first presentation, we don't have to forget the other topic, the other issue, like food security, ensure access to water, and also the issue of security. You know, when people become or get the feeling to be threatened by someone who is contagious, and the level of violence can increase a lot, and exactly what's happened during Ebola. Of course, in this situation, the fatality rate is not the same as Ebola, but it's something that we need to take into consideration, because we can have also some security issue on this. And the challenge is also, how can we improve our level of care, but also with limited resources. It's nice to say that we need to wash hands, but when we don't have water and soap, when we do not have access to alcohol-based hand rub solution, it's nice to ventilate patients, but when we do not have electricity, we do not have oxygen, we do not have consumable, we do not have maintenance, and maybe we have professionals who are able to use it, but they do not have the minimum needs to operate. That's why we always need to adapt our standards to the reality of the field. And that's why the presentation of Angela was very interesting, because it gives also the flavor of the field, and to show that to write books and guidelines is very important, but in the end of the day, it needs to be applicable to the reality of the field. That's what I wanted to say on the different presentation. I don't know if you want to conclude, Luca, as
No, nothing to say more. Thank you. I would say thank you very much, Olivier, for your availability, and thanks for chairing the session. And I hope that everybody enjoyed. And I'm very proud of this joint collaboration between CRIMEDIM, UKMed, EMDM, and the No Fear project. So thank you very much.
Thank you all. Thank you very much for
Thank you
allowing
all.
this.
Thank
Yeah,
you.
yeah, and for
And stay
participating.
safe. Stay safe.
You too. Thank you. Bye
Bye-bye.
bye.
Bye. Good.
Bye.